Good morning, everyone. Assalamu alaikum warahmatullah. I'm Dr. Ali Sarawi. Thanks for the scientific committee for giving me the opportunity to present. So our topic today is about IgG4 related disease, advances in pathophysiology and treatment. So first of all, I have no financial disclosure or conflict of interest. So I hope by the end of this lecture that you will be able to define IgG4 related disease, list the main manifestation of IgG4 related disease, categorize the most common phenotypes of IgG4 related disease, detect radiological and pathological finding of IgG4 related disease, validate the classification criteria for IgG4 disease, and build treatment plan of managing IgG4 related disease. So first of all, it's an insidious, progressive, highly destructive disease that's sometimes fatal condition. The main characteristic of this disease is chronic activation of the immune system and tissue fibrosis. In several studies, the estimated incidence was around 0.78 to 1.39 per 100,000. And in Japan, also another study showed comparable results. So what happens in IgG4 related disease? So we have several elements of the immune system involved. We have several antigens like galactine, prohibin. We have also involvement of the innate immunity, like eosinophils, basophils, and M2 macrophages. We have also T cell involvement, and as long as also B cell involvement. So what happens? Usually, we have a trigger from either an autoimmune antibodies with autoantigen presentation, and sometimes an infectious agent is related, which activate the innate immunity. Both will do molecular mimicry. And we have the T cell involvement with production of several interleukins, like interleukin-5, which will increase the production of eosinophils, and this will lead to serum eosinophilia or tissue eosinophilia. We have the interleukin-13, which will, as long as interleukin-4, which will activate the production and proliferation of B cell and maturation into plasma cells, which eventually will lead to production of IgE and IgG4, which will infiltrate the tissues. We have also TGF-beta, which will increase the production of fibroblasts, which will lead to tissue fibrosis. All this massive cell infiltration will infiltrate in the affected organs, leading to enlargement of that organ. Also, the immune complex will lead to epithelial damage, and this will lead to organ dysfunction of that organ. What are the clinical features? So having an acute or fulminant signs and symptoms does not occur in this disease. And instead of that, we do have usually a subclinical signs and symptoms that will go over for a very long period of time. And sometimes these signs and symptoms are undiscovered by the treating physician. And usually, most of the time, they were incidentally discovered in imaging and or in surgical pathology. We have many organs, as you see here, involved in this disease. The most frequent ones are salivary and lacrimal glands having asymptomatic enlargement. Some patients, they may have some dryness. We have also diffuse pancreatic enlargement with maybe pancreatic failure, either in endocrine or exocrine parts of the pancreas. Also, we have a retroperitoneal fibrosis, which may go and encase the aorta. Less frequent organs involved like the orbits, where we have asymptomatic masses and maybe extraocular muscle involvement with myopathy and myositis. The lungs could have some nodules or masses. We have also bile duct involvement, either intrahepatic or extrahepatic. We may see some focal masses in the kidneys. And the least are actually pachymeningitis, thyroid gland involvement, and aortic wall thickening or aneurysm. Yeah. So most, like 60% of patients, they do have a very long latency period, which like at the time of diagnosis, it goes irreversible. They have irreversible organ dysfunction. Usually, we do have some gross changes in the organs involved. So either some organs will be enlarged, and some the ductal organs will have a pipe stem or diffuse wall thickening. In this picture, we can see that there is an enlargement in the lacrimal glands as well as the salivary glands. Also here, we can see the lacrimal gland involvement. We do have some distinctive phenotypes of this disease. One of them is the pancreaticobiliary involvement. Usually, we see it in older male patients with very high level of IgE and IgG4, and it involves the pancreas and the biliary system, and usually they are treatment responsive. Other phenotype, which is the retroperitoneal or aortitis. Also, we see it in older males, and with not a very high IgG4 level in the serum, but they do have high acute phase reactant, and it's characterized by fibrosis, and it is difficult to treat. The third phenotype is head and neck involvement, where we have sinusitis, some internal ear involvement, lacrimal gland, and thyroid involvement. We tend to see it more in young Asian females with marked IgG4 level, and it's difficult to treat also. The fourth one is Mikulicz or systemic disease, where we have almost like all organs are involved, like lacrimal glands, salivary glands, lungs, kidneys, and others. We see it in older male. Also, they have marked IgG4 level with IgE, and they are treatment responsive. So the most common one actually is the pancreaticobiliary disease in 31%. Retroperitoneal and head and neck were found to affect around 24% of cases, and the systemic involvement is found in 22% of cases. This is in a study by Lanzillotta. Radiologically, this is a CT scan showing a sausage-shaped pancreas with a diffuse enlargement. This is the classification of the biliary tract involvement. So type 1, when we have a lower CBD stricture, and usually with acute pancreatitis, autoimmune pancreatitis. Type 2, diffuse intrahepatic cholangiopathy with a lower CBD stricture. Type 3, hilar and lower CBD stricture. And type 4, hilar stricture alone. In this CT scan also, we can see that there is fibrosis in the retroperitoneal and encasing the aorta. Same picture again, but we can see here the enlargement of the lacrimal glands and the salivary glands. So histologically, the characteristic finding is the storiform fibrosis, where we see in the arrows, you can see the fibrosis, and in the stars, you can see the cellular infiltrate. And other common findings are the lymphoplasmacytic infiltrate with IgG4 plasma cells. We may see eosinophils, but not it will not be the dominant cells. We can see also obliterative phlebitis and accumulation of IgG4 class switched plasma cells. So we'll go over the ACR Euler criteria for IgG4 related disease. So we have an entry criteria where we have an characteristic clinical or radiological involvement of a typical organ that we mentioned in the beginning, or a pathological evidence of lymphoplasmacytic infiltrate of uncertain etiology. We do have several exclusion criteria. So clinically, if patients have fever, they have poor response to steroids, marked leukopenia or thrombocytopenia, or peripheral eosinophilia more than 3,000, this make it less likely to be IgG4 related. Serologically, if we have any of the typical or specific antibodies like PR3, MPO, anti-Rho or La, extractable nuclear antibodies, cryoglobulin, all of these may make it less likely to be related to IgG4. Radiologically, if we have rapid radiographic changes or progression, if we have large bone abnormality, if we have splenomegaly, and if still there is a concern about infection and or malignancy. Pathologically, if we have a primary granulomatous inflammation, if we have necrotizing vasculitis, malignant infiltrate, prominent histiocyte infiltrate, or neutrophilic infiltrate, multicentric Castleman pathology, prominent fibrosis, or inflammatory pseudotumor pathology, this will exclude IgG4 related disease. So if the patient have the entry criteria and has none of the exclusion criteria, then we can go for the inclusion criteria. And we have to calculate how many points we have. The higher the IgG4 level, the higher the points. Histologically, if we have a storiform fibrosis with lymphoplasmacytic involvement, this will give a higher point. If we have involvement of lacrimal and salivary glands, then this will give you give a higher points. If we have a chest or thoracic wall aorta, chest or thoracic aorta involvement, then we'll give higher points. Pancreas and biliary tree, kidney, and retroperitoneal fibrosis. We need a score of 20 or above to classify as IgG4 related disease. So in a study testing this classification criteria showed a sensitivity of 88% and specificity of 87%, which is pretty good for a classification criteria. Regarding the management, we have many proposed medications, like for example, in many RCTs with different protocols, they used the glucocorticoid and showed like improvement, and actually it's the mainstay of treatment. Some case series showed like some patients, they may improve with azathioprine. Also methotrexate have been used, but mycophenolate was seen in several RCTs showing good results, but the best evidence comes with rituximab in combination with steroid in different protocols. So what is the outcome of this disease? This is a study showed that many patients will stay like unrelapsed. Like the persistent remission rate was around 43% after 72 months of diagnosis. and the relapse rate was around 55% after 72 months. The main organs involved in relapse were actually the lacrimal gland, and the least one was if we have kidney involvement. The higher the number of the organs, the higher the risk of relapse. In this study also they showed that if we have glucocorticoid monotherapy, they have a higher risk of relapse more than patients who receive glucocorticoid in combination with immunomodulator therapy. And also patients who withdraw all the drugs have a higher risk of relapse compared to patients who stay on glucocorticoid plus the immunomodulating therapy. Also, the higher the initial dose and the maintenance dose have showed less risk of relapse. Also, other factors may increase the risk of relapse are the higher the eosinophilia, the higher the IgG4 level, and if we have re-elevation of IgG4, this make it more risk of relapse. So just in conclusion of that study, long-term glucocorticoid and immunomodulating therapy control the IgG4 related disease. And if we give combination, this will decrease the need of higher steroid dose. Other causes of relapse were the higher the IgG4 concentration, the higher number of organs involved, the higher the IgG4 scores, low maintenance dose, and history of eosinophilia and allergy at baseline. So this is my last thing, and thank you for listening.